Assalamu alaikum. Welcome all to our Bangladesh Radial Live 2020 virtual summit. And we have done 2 live cases since morning. So this is our live case session 3. It will be directly telecasted from National Heart Foundation Hospital and Research Center. So our chairpersons in this session, Professor Huay Cheem, and then he's the director and chief consultant of National University Hospital, Singapore. And I am Professor Sabina Hashem, and Professor SM Mustafa Zaman is another moderator. And our panel of experts are Professor Prabir Kumar from Chattogram Medical College, Dr. Mahbubor Rahman from Labin Cardiac Hospital, Dr. Kaisar Nasrullah, Senior Consultant, United Hospital, Dr. Tamzeed Ahmed, he's a consultant from Evercare Hospital, Dr. Mohsin Ahmed, he's a consultant, associate professor in ICBD, and Dr. Shams Munwar, he's the senior consultant of Evercare Hospital. So may I ask the chairpersons and the panelists to chair the session.
I am Professor Mustafa Jamal. With the permission of the chair, actually we are learned chairperson, and we are very, very world-class renowned interventional cardiologist, and our panel of experts are also very learned person. And already we have observed 2 live sessions in the morning, and we hope this will be an exciting session, and a lot of panel of experts and our chairpersons will discuss, will share our knowledge. And I don't know from National Heart Foundation they are ready or not. And with the permission of the chair, and the chair, 3 chairperson already, Dr. Sabina already mentioned. So from our chairperson agreed, and we'll start the session actually.
Yes, thank you very much.
Madam, এখন শুরু হবে.
If it's possible, if it's ready for the transmission.
Can we start and present our case?
Yes, madam, you can start.
Yeah. আমি এটা ভুলে চোখ দিয়েছি। ঠিক আছে, ঠিক আছে, চলে আসছি। Can't hear. Hello, sound please. Actually, we could not hear actually. IT sector, please.
What Heart Foundation এর কথা শোনা যাচ্ছে না? Cannot hear.
Sound please. We can't hear.
Okay. They can't hear us. So if they can't hear, please, Tawfiq, can you fix this?
Now, madam, we can hear. Please.
Now, am I audible?
Yes, you are audible.
Okay. Yes. So I'm Dr. Ashok Datta from Heart Foundation. Good afternoon, everybody, and welcome to our live case. This is a patient of 47 years old lady, recently diabetic, non-hypertensive, having effort angina. Recently, her angina was class 3 to 4.
Yes.
And ejection fraction was 45 to 50%. Creatinine level was normal. And 2 days back, day before yesterday, we did the angiogram that shows right coronary. Dr. I'll request, that was the ECG at rest. And this is the angiogram that was done day before yesterday. That was done through distal radial. Right side, please. Severe left main, osteal LCX, as well as osteal LA dilation. RCA was normal, and there is no collateral from the RCA. So this is unprotected left main with osteal LAD and LCX. Syntax score, how much that was? 20?
No, it's 30 something.
32. Yes, 32.
32.
So
basically,
opinion from the panelists, please. What strategy we should follow?
Anybody, our chairperson, Dr. Tanwa Cheem, can you say something
Can I see
about the strategy?
spider view? I can't see.
Yes,
whether
spider, please.
Please, there is angel view, please
Is
again.
it a 110 or 111? I'm not.
111, I think, sir.
it's a
111.
111. It's a 111.
Do you have a spider view or that I can see?
So actually, on during angio, patient had severe chest pain, so only these three views are taken.
I see.
So actually what happened is today while we were preparing the patient, we were all set to do OCT and pre-procedure OCT to make sure that it was a Medina 111, and we've got the spider view also. So we had quite a bit of excitement and adventure actually because she arrested on the table. So we revived her and we are doing the case now. So Moshed can maybe show you, first of all, there was this huge tortuosity, so we had of the radial, so we had to do a balloon assisted tracking, and after we did balloon assisted tracking, while we were taking our catheter, our patient arrested. And okay, so as you can see, her heart is barely moving, and then there was this straight line, and then we're giving CPR, and we gave intracoronary adrenaline, and the heart has started to move. So this has happened like 20 minutes prior, okay? So the heart has started to move. We put the catheter, and I hope we have so we wired the LCX promptly. After wiring the LCX, we take a wire for the LAD.
Next.
So
LED was severely angulated from the left.
And it's like a 99% lesion, and it's severely angulated. We are struggling with wiring the LED. Yes. The patient has already arrested, and then you can see, and here you can see that it's a Medina 111. The 99% LED, 95 to 99% LCX, and also the distal leftment. So this is Medina 111. We wire, then we take another wire, we manage to wire, and then we immediately pre-dilate. Once we have pre-dilated, she settles down. And she was having constant chest pain these last 2 days. Then we pre-dilate the LCX as we know that it's diseased. And we actually couldn't wait for the conference or the live case to start. She was so unstable. After this, we take a stent for the, so this is, now you can also see that the LCX is diseased. This is after pre-dilatation. We've pre-dilated both the LAD as well as the LCX. After pre-dilatation, this is how the vessel looks. We take our stent for the, we attempt to take our stent. First, we take a balloon for, from left main to LAD, then we try to take the stent, but the stent wouldn't go. So we changed again and took the balloon first, and the stent first, and then the balloon. We position our stent and we deploy it.
DK crash plan is.
So we've already decided on an upfront double stent strategy, and we've decided on a DK crash technique because we think that will give the best possible results. We've deployed our Resolute, Endeavor Resolute, and then we remove our wire and we crush the stent. So this is where we are right now. We've just crushed our stent from in the LCX, and now we've just managed to rewire the LAD.
LCX.
We've rewired the LCX, sorry. So rewiring the LCX, initially we rewired, but our balloon wouldn't go. So then we changed the position of the wire, and now our balloon has gone, and this is where you have joined us. So we're taking our balloon now.
Sometimes we do sequential crush, you know. Is that Fazila Malik? Switching here.
Yeah, this is
so I can't see your face, sorry.
Hi. Yeah, sorry about
we
that.
sometimes do sequential crush. That means you take a balloon which is sized to the LAD, and then you take a bigger balloon, which is sized to the proximal vein vessel, in which case is a latin, to crush it further so that you can have it's a little bit like port. You facilitate the entry of your wire into the side branch.
Right. That's a great suggestion.
So, yes.
So this is we're trying to open up the strut of the LCX, and once we've done that, we're going to do our first case. And
so
we'll open up the stent.
So Fazila, I think the recommendation is to go through the proximal cell in a DK crush technique. So how do you assure that you are in the proximal cell?
I think I am, but once the thing settles down, maybe we can take an IVUS catheter and you can have a look. It look like
push, ma'am.
Yes.
It looked like proximal to us. Proximal or middle strut. That's what they recommend.
Negative.
Sometimes I leave the first wire in the circumflex crushed without taking it out first, and that will serve as a marker for a new wire to go down, to go parallel to the trap wire, so that you will always be assured that you're in the proximal cell.
I mean, that's a nice way to do it. But, what I feel is I have reservations about, having my wire in that crush stent, and what if I can't, pull it out. Sort of would be a nightmarish situation. So I take my luck and I just pull the wire and the balloon. But as you rightly pointed out, that is one way to make sure, because if you have a wire there, obviously rewiring and going proximal to that wire is a great idea to understand where you are. So now we're going to do the first case.
Are you going to do some imaging now, Fazila? Or?
Oh, if you want to, we can. We'll just do our first case, and then we'll... So the fact that she became very unstable was a bit unsettling.
Sure.
And so we're trying to work through a 6 French guide catheter, because we're doing an upfront double stent technique. Huh?
Balloon neck to back, wire take to back, wire, L6 7. Are to push me? Are to push?
Is this a O balloon? So the balloon didn't go.
You need a smaller balloon, or
maybe, or a better profile one. So this is 2.75 12 NC balloon that we're taking through it's NC Euphora by Medtronic. We've already deployed a Medtronic Resolute stent in the LCX, which was a 2.75 by 30. And we've already crushed it. And now we're taking our NC Euphora by Medtronic for the LCX. So this is our first case. And actually working through a 6 French to do double stent technique can sometimes be a bit of a struggle. But our balloon went well. We'll take our second balloon for the LED.
This is 3 or 3.5?
This is 3 by 12 NC Euphora.
Fazila madam, can I ask one? N16, how much it is enlargement? It's for Muslim.
So it's like around 2 millimeters, maybe. Not too. You want to make sure that you cover the ostia, but you do not want too much of overlap. So it would be like 1 to 2 millimeters of the stent.
Good. Okay, ma'am.
Yes, 2 to 3 millimeter is the recommended length to be left in the main vessel.
Yes.
What size are you going to choose for the main vessel balloon?
Maybe we can do a bit of imaging and sort of ascertain that if the patient tolerates that. So, you know, taking the balloon is a struggle. It's not moving.
There was brachial loop.
Because she's got this brachial loop, and you know, balloons and stuff are not going easily through this loop. So that is also another issue that we had to deal with before she got arrested, because there was this loop and we couldn't wire the vessel, and then we had to do balloon assisted tracking to get our stuff in. So now we are in business. We've managed to push our LED balloon. We'll position our LCX balloon and we'll do our first case. So that's us.
Do you prefer to use a 7 French or 6 French for such two-stand bifurcated?
I prefer 7 French, but today it was
transradial course.
Yeah.
No, it's a push LED back. Okay.
For a South Asian lady, it's very difficult to put a 7 French in a
absolutely
by the radial route.
She was, you know, she was in constant agony with the chest pain and all. She's been very.
Yeah, she should be quite stable by now. I think.
Okay, so which one is the L6? We don't want to get the LED.
This is the LED.
The upper one is
upper
yeah.
One, so
we'll just make sure. So this is the LCX. So I'm pulling out the balloon. I'm going to
resistance.
That
angle, that brachial.
Can I have a question to the Dr. Tanhua?
Yes, you can.
Actually, this is a very critical situation. The patient is in the cardiac arrest, and now the cath lab is well equipped with the manpower and others. But in a normal situation, when that is happen with less manpower, what is the strategy should we go for? Should we go for the SKS, simultaneous stand kissing strategy, to go to the true stand and just deploy?
Yes, I can understand. Actually, Dr. Tamrachi, Dr. Podip has mentioned that what should be the strategy in case of not well equipped cath lab, just not like this cath lab. So, which strategy do you prefer in that type of cath lab actually?
I think when you are in a very dire situations like this patients who had a cardiac arrest, the most important thing is to establish upflow. The moment you can do a balloon angioplasty and open up the circumflex, preferably without the LED, I think the patients will be immediately stabilized. And then you have a choice of your two-stand strategy. I think you should be doing the strategy that you're most comfortable with, whether it's Kuloy or whether it's tab or whether it's DK crush. It has to be something that you're so familiar with that you can do it in a quick and meticulous fashion. But I think in this case, the anatomy is not so suitable for T-standing. I think the angle is fairly narrow. So either Kuloy or DK crush or classic crush will be helpful, or mini crush, whatever you call it.
Thank you.
Is somebody go for the sequential stand, simultaneous stand kissing, SKS? What is your opinion about the SKS?
I don't like this SKS technique because it creates a huge new carina here, and it will be a problem later on if the patients have restenosis stream or something like that. So I don't like SKS as a technique.
So now we are doing an IVUS run. As she's all, so let's have a look. And we are in the LED. This is the
Focus on IVUS, please.
Focus on the IVUS, please. Can you see the IVUS image?
Yes.
Yeah. So,
Yes.
So that's maybe a diagonal, and there's some plaque burden.
Yes,
this is
LED.
quite a bit of LED, very disease, and you can see the angiogram as well, corresponding angio. Huge plaque burden. It looks relatively better. Some amount of calcium there from 6 o'clock to 9 o'clock. Again, some plug.
Left hand.
No? No.
This is LCX ostium.
So is it?
This is
the LCX.
Distal left vein and LCX.
So the wire is, can you see the wire is right in the middle? So we went to the middle strut, and that's what they suggest. Either go to the middle or the...
Good.
So we were through the right strut, which is a good to know.
What about the distal caliber? 3 or 3.5? Hey, patient is moving.
So what is the reference vessel diameter of the LAD and the left main here?
Yes, please. What is the estimated diameter? Tell us. Now,
on view.
We'll do an angiographic view also.
After nitro?
After giving some nitro. And you can focus on the, please, hemodynamics as well, the IBUS and the hemodynamics. Okay. No, this is, we have to go with the real. It's a bhool to bayre the hai.
The diameter is 3?
No, that's that's the plug with the plug burden.
How about media to media, the diameter?
Yes, so yes, media to media. That's what we're going to do. Bayre jaba. Can you do the have
needle on needle. Over the charak needle. Another needle place.
Go to fluoro. Please. The patient. Pressure
is okay.
Pressure drop course GTN, please Sabina. So we gave GTN and the pressure has dropped. So we need to, I think, DOPA is going on. So yes, so there's huge size disparity, right?
About 3.5. 3.5, 3.8.
And 3.8, approximately 3.8.
I always size it more conservatively. I sort of downsize by half using IBUS. So I'll take a 3.0 and then I can go higher pressure if needed.
So distally, it's a 2.5. So what you're going to do, we're going to use two stents. One for the LAD, mid LAD, and one for left main to LAD.
Yes.
So that should be better sizing of the, and give us overall better results. Instead of using a very long stent, that's what we plan to do.
How big is the left main here?
Left main?
Have a look at the left main. And someone start the DOPA. What is the dose of the DOPA?
All right with them. No, it is now patient is 110 over 80.
Right, it is also all right.
We need a stent that can be expanded to the size of the left main artery diameter.
We'll do that. So we'll use the onyx for the left main to LAD. We'll use the onyx for the mid LAD. We're using a resolute for economic purposes.
This one? একটু দেখেন একটু ম্যাডাম ফুল করে দেখেন একটু
হ্যাঁ
না এটা আচ্ছা ওকে yes
we'll remove the LCX part. For mid LAD we don't have to worry about the LCX part. So we are taking our stent for the mid LAD, which is a 2.5. It's a 2.5 by 24.
Yeah.
It went easily.
Back, man. Check. So,
Take your time. You don't want to get any.
yes, yes.
So have a look at the hemodynamics. Sophie, can we have a look at the hemodynamics? So she's settled down
Yes,
now.
you, ma'am.
Yeah.
Yeah. Is she on any inotropes now?
Only in dopa minimum dose 5 max.
I think
So
she's good.
Yeah.
Just don't give any more nitro.
No, we won't give her any more nitro because the nitro are we sure with the position?
Yes,
Are we
yes,
happy?
yes.
Yes. So we're deploying our mid LED stent. We went to 10,
11.
12. We'll pull back and go up a bit.
Yes, yes.
Now, one thing I like about the DK crisis is that you have access to your main branch
12,
all the time.
14, 16, 18.
Fine.
And you preserve your side branch almost
Yes.
certainly. Yeah. So
Yes. And so we're going to take onyx so that we can, sort of post-dilate it to the optimum size of the left main. It's going to be matching the left main as well when we post-dilate it with a larger size balloon. So that's the great thing about onyx. And it's got great radial strength. So it's good for a left main. And it's got very good side branch accessibility. So recrossing, usually touch wood is not an issue. Yes, please.
Are you going to overlap with the distal stent?
Yes.
Honestly,
you need a fairly long stand here.
Yes.
Now pressure is on 40/85.
So the pressure now, we can go to the hemodynamics at 140
Actually,
now.
very much sensitive.
Yeah.
This group, madam always tell, this group of patient in our country very much sensitive to nitro.
Yeah, so maybe we can stop the dopamine already. The heart rate is too fast.
Yeah. It's just like, yes. So maybe we can lower the dopa dose if required. It's only 5 mics. It's 5 mics.
Yes,
Yeah.
Madam told very correctly that in our country, nitrate we do not give mass.
তাহলে কি দিয়ে বলো ওটাই দাও 3.5 দাও 3.5 দেওয়া উচিত না
3.5 better 3.5
3.5 দাও
3.5
3.5 দিচ্ছি হ্যাঁ
3.5 so 3.5 38 38 38 yeah
We shall overlap.
Dr. Ashok, the stent you implant in the medial edge, it is 2.75 or 3?
2.5 2.5 only, and we go up to 18.
It's around 3 now.
This is important because
So we'll get the out the wire. Yes, we will. Just once we take the pen, position it. So the loop in the proximal part of the vessel doesn't help. It's a pretty bad loop.
It's good.
So
Deliverability is
here we are. Right.
LCX.
We're taking out the LCX wire now.
Keep the space for port 2.
Yeah.
Yes.
The overlapping
without
is
that,
Do you
there is
intend
overlapping
to
of
cover
one
the ostium of the left main or not?
No, we are not
ostium
planning
we
to
want to spare the ostium because ostium is good. The ostium we can check with a small amount of dye. Yes. So our target is the distal overlapping should be the perfect.
Looks like it's covering the ostium as well.
So it is out of ostium. No, this.
Yes, interior to the ostium, approximately 5 millimeter inner to the ostium.
Oh, okay.
So it's not covering the ostium, right?
Yes.
And it's covering it's overlapping. Just one thing that we really have to make sure is that our stent is overlapping the previous one. Because if it doesn't do that, we'll be in big time trouble.
Yes.
So it's like 2-3 struts, right? We're all right with that.
Overlap.
Yes. So
Looks good. Sometimes the long stance, I give it the longer duration of dilation, to just allow the stent to fully expand.
Millimeter push.
So
the Japanese like to dilate 2-3 times of 30 seconds.
So now we'll post dilate. Now after post dilatation, we will do proximal optimization, and then we will rewire the LCX because otherwise, if we do not do proximal optimization, there is always the chance that our wire might go under the stent and that might cause problems.
এটা কখনোই এক হাত দিয়ে খুলিস না, দুই হাত দিয়ে খুলিস চার্জের পয়েন্ট।
So now we are taking a 4x8 NC balloon to do proximal optimization. We will place our balloon at the carina and do our proximal optimization so that the struts of the proximal main branch get properly opposed to the left main.
Do you want to post dilate the LAD as well?
Yes, we will do that. Once this is done, we'll definitely do that. Where's the balloon?
The balloon is
Yes, please.
No.
So what balloon are you using for the post dilatation?
So the balloon is the NC Euphora. Yeah, can we have a look at the carina, please?
Yes.
We are at the carina, right?
So the teaching now is to put the distal marker right at the end of the carina, just the beginning of the carina.
A bit full man.
We came out of the stent,
No. A bit full man. A bit full. Yeah. A bit full, a bit, yeah.
So we are in the carina now.
Yes. Distally in the carina and proximally just at the proximal part of the stent.
So we like the distal marker to be right at the carina so that there is a proper
Gone up to 18. Little bit back, there is a small, there is Austrian. Yes, okay.
We're inside the stent?
Yes, inside the stent. So again, I am putting 16, 18.
So we are going to high pressure, 18 atmospheric pressure with this NC Euphora by Medtronic.
4 into 8.
How big is this balloon? It looks a bit small to me.
4-8.
It's 4-8. 4-8.
Okay.
So we can do two things. We can rewire the LCX right now, or we can do the post dilatation of the LAD. We can do the post dilatation of the LAD later on as well once we finish. Yeah, after the second case, we'll do the post dilatation of the LAD and we'll have a imaging again. So now the next crux of the matter would be to rewire the LCX again through the proximal or the middle strut, which we have to do in the DK crush.
Yes.
Madam, is there any rule not to cross the LCX in this spot?
Yeah, in the proximal optimization, we always have to put the stent, the balloon in the carinal level. So
carinal level. Never cross to the side.
It is the carina. You should not cross the carina.
Yes, and it is the rule.
So maybe Fazila, you want to explain why do we have to go by the proximal meat and not at the distal cell of the side branch stent?
Yeah, so with a DK crush, you want to go through the proximal, but with the other techniques like tap or other techniques, you go through the distal strut. Here, you go through the proximal strut. In those techniques, you want to scaffold the side branch, but here you're crushing. So it's the whole game. And I think Dr. Ormiston has great models to show why it has to be done. So anyone interested can look into that. So I pushed the micro deliberately into the LAD just to make sure that I'm not under the stent. So the micro went very easily. So I'm definitely, hopefully in the lumen. Now I'm going to pull back my micro, position it near the LCX, and I'm going to hopefully get my wire inside the LCX. Now this is distal, right? We want to be more proximal.
Yeah, this pullback technique is better for the distal cell approach, but for proximal cell, I tend to just go as close as possible to the beginning of the osteomolding.
Yeah, that's true. So it went, and we'll just take our micro as well to see whether, so it goes very easily.
Yes.
So now we'll remove our micro, and we will do our final case, our report, and do post dilatation of the LED, and then we'll have a final imaging. And we are hopefully within time, right? So our session ends at 4 o'clock.
4 p.m.
Yeah, so if the panelists have any questions, queries, or any suggestions.
I have a question. Madam, I have a question. You have recrossed the LCS 2 times. You have recrossed the LCS 2 times, right?
Yeah, with the PK cross, you have to recross the LCS twice.
Yes.
That's why it's part of the
Last time you did not use the micro catheter.
Oh, okay. First time they didn't give me the micro. This time they decided they wanted to show off a micro. That's why they gave me a micro. It doesn't matter.
Madam.
You don't need a
without micro, we can cross because that is costly. What are the other non-costly technique to cross the
If you can cross it without micro, that is good.
Yeah. So now we're taking a 2 millimeter small balloon to open up our strut. Once we do that, you take the kissing balloons and do our final case.
As because your micro entered easy, so 2 millimeter balloon into the side.
Thank you, madam, for the nice demonstration. Professor Amal Kumar Chaudhary's question regarding actually operator experience is the give you a main strength for success, because if you know how to manipulate IR, it is okay. Then you can go in the IR. Whatever the technique you prefer, you can do. But again, we learn a lot from this.
We can have a look at the IVERS also if we want to see whether our strut is distal or not.
Or what really goes on when the ventricle fails. For you to there's all of this. Now here is again.
There's difficulty, you might use a smaller balloon, or you can put the balloon in the LED and anchor it in.
Yeah, that's also a great suggestion. Huh?
You can plug a balloon in the LED and this.
So now we're taking this balloon out and we're taking a balloon to anchor. Okay, let it be here. We'll take a balloon in the LED to anchor our, as Professor Cheem suggested.
Yes.
So we're taking a second balloon to anchor, which will give us better support. You see, with the radial, you have problems with support.
Yes.
With the femoral, you don't really have these problems. And in an ideal world, I would be doing this through femoral. But today, it's the BRIC, right? So it's a radial program, and you have to do it through radial. That's why.
And thank you, madam. But radial and femoral, I do not think different, as because you are radial, you are femoral, you are also radial. You will be also radial, because only entry pathway is different. Otherwise, work is everything same.
The work is absolutely same, but you see, the support is actually better with the femoral. That's my feeling. But if you have the starboard, so here I was planning to show you the starboard. So this is something that the Europe Teremo has, and we got it. So that really gives you the feeling that you're working through the femoral. So we use starboard by Teremo.
Zilapa, I think it was an emergency case, looks like. Would you have been thinking about going to femoral in this case, but if you needed any assist device or ventricular support during your procedure, you didn't need it?
We don't have any assist device. This patient was having chest pain. But
you did very good job. Yeah.
He went into arrest while we were trying to take the catheter. So it happened on the table. So
yeah, I
we
didn't
had
have time
we were
anyway.
already,
Yeah.
we were already through the radial route.
Yes, yes.
Okay. Oh, now it is
Now it
going.
went.
Yes.
Now just with the support of that. So we're opening up the strut now.
It's the anchor
18,
technique.
18. To push my L6? Yes. Now LED push. Yes.
We can.
So again, we are dilating the post-dilating the LCX.
Now so now we're going to do the
No,
kiss. Yeah, but this is an undersized balloon. We need a larger size balloon to do the kissing.
And we still have to post-dilate the LED, isn't it?
Yes, we have to do the post-dilation and we also have to do the report. So, we are taking a balloon for the LCX now. Yes, we'll do the post-dilatation as Professor Cheem suggested. So let us do the post-dilatation and after that we can do the kissing, right? We'll go first distally.
This is the overlap part of the
stance.
Yes, this is the side.
What pressure do you give for post-dilatations, Fazila?
What
pressure do you inflate for post-dilatation?
18.
We are going up to 16, 18.
18, usually 18, sometimes 24.
18.
Yeah, 18 to 20.
Yeah.
Usually we are very much liberal for post-dilatation. Sometimes 24. Yes.
Yeah.
L6.
So it depends on the lesion also. So now we'll take the LCX balloon. And this is a
275 or
2.75, 2.5? 3.
LCX stent was 275, but
So
now balloon we are taking 3. 3 into 12. And for LED it is 3.5. For LED it is 3.5. Stent was 3.5 and balloon is also 3.5. And for LCX a bit oversized balloon.
Why LCX is a bit oversized? What is the idea?
Because distally it is 2.75, but proximally I think a bit size is larger. A bit larger.
So are we doing a sequential kissing here, Fazila?
No, we're doing just a simultaneous kissing. So we will go up together, we'll go together up and then come down again.
They do recommend the 2 steps kissing if you can. You know.
Yeah, nowadays they recommend 2-step, right?
Yeah.
But what's your experience? Do you like the 2-step or do you want to?
I do the
are you all right
steps. I do the 2-step. I pump the balloon.
So what do you do?
Just proximal to the carina to the ostium, not too much into the main vessel, just a little bit into the carina in the 2-step kissing.
LED would go. So LCX stent is going.
So this is our balloon for the LCX. Now we'll position our balloon for the LED. We need to push both. We need to push both.
Both at 12 millimeters. Yeah.
So I think we're just at the edge, right?
We can go.
No, let me position it first. We don't want to.
Let's push.
Okay, so
LCX.
I'll push the LCX and do the pre-dilatation of the LCX, and then I'll post-dilatation, and then I'll do the kiss. Okay?
Or
it's not going down actually.
Okay, we can do here. Yeah.
Let me no. Let me put the LED. Let's not rush. I'll need to put the LED a bit proximal.
Oh, catheter.
Getting a bit clumsy, right?
Yes.
Actually,
one
no
is
need to be too proximal, Fazila.
No, I don't want to. I don't want to do it too proximal.
This LED লাগবে, LED টা একটু পুশ করতে হবে। This is একটু পুশ করতে হবে। আরেকটু এদিকে, yes.
So we're all right now, right?
2, 4, 6, 8, 14.
Usually for kissing, we keep it at nominal pressure, but if we do a two-step, we can go high pressure on either side.
Yes, yes. Here we went to 14, so which was pretty much nominal actually.
Just speaking about sequential.
Yes, then sequential you go high, yes. This balloon won't go actually. I'll get it out. Now we need to do the report. So we've done we need to do the report and maybe imaging. And also if any post dilatation is required of any of the vessels, do that as well. So I'm getting the LED stent balloon as well. So second kissing has been done. And you see, this is the beauty of DK Crush. You hardly use any dye at all. It's like following the recipe. That's what I say, It's like you just follow the steps, the recipe, and everything sort of happens one after the other. So that's what I love about DK Crush. You don't have to lose the main branch. You'd always have access to it. You safeguard your side branch, and you'd hardly use any dye because you're just following the steps. And it's
that's because you're very experienced, Fazila, because people will complain that this one is a very tedious procedure. There are multiple steps involved here. In fact, there are 7 steps involved here. So it takes experience and a skillful operator to do this properly.
Yes.
Well, thanks for the compliment. I'll take it as a compliment. That was very kind of you.
For an expert of DK Crush, it is easy for her.
What is your DAPT regimen for this lady?
But she's young, so we might prolong her DAPT. At present, she is on Ticaral and Ecosprin, aspirin and Ticaral. So we want to position, so this is our second report, and we're a bit slightly away from the carina now.
18.
This is 4.5 by 8 now.
Yes. Do you use a semi-compliant or a non-compliant for your port?
We go for NC.
NC only.
I mean, lots of people do propose that semi-compliant also works very well for them. And actually, with a semi-compliant, you're absolutely sure that your struts will be opposed. But with NC, there's no surprise of over inflating or anything.
Particularly if you
so now we'll take an IBUS, okay?
Yes, please.
Over a little.
So nice presentation, actually great presentation, and in an emergency
Can I add one point,
in this scenario. So without any hurry, actually it's a nice presentation, and I think without you have all sorts of hardware support and step-by-step procedure you have presented. But my question is to you, Professor Fazila Madam, actually you are very skilled. For that reason, without any hurry, you have presented so nicely and with coolest way. But I'm asking you, the junior fellow, what type of actually tips and tricks and what the message you want to give them in this scenario? Because in the morning session, Professor Jamal also presented bifurcation, enlightenment bifurcation. Actually, he did tap because the angulation was very fine. But in this scenario, you did DK Crush and the step-by-step presentation so meticulously. So actually, for your junior fellow, what message you wanted to give actually?
Well, honestly, shall I tell you, the secret of success is to have a team that is so well developed and team members are even better than you are. You make sure that your team members are, even more skilled. So when you have a great team, you don't really have to worry because you know the team is there for you. And you try your best, but and you try to keep your calm, and the team is there to support you. I think that is so. You have to improve the skill sets of everyone. That is, I think. So now we'll have a look with the IVers.
Live IVers, please. Go live on IVers, please.
Okay, so maybe it's we pushed and pulled, so maybe the IVers catheter sort of lost it. We'll try again.
You can take another IVers.
We will take another if required. Yeah, we'll wait for a bit and see. The IVers isn't. So this was a bit of a challenge, right? Because she was having a lot of chest pain, and she is
I think we have.
We will change this, right?
Yeah.
Oh no, it's come. It's come. Okay, it's working. So can you show the IVers, please?
Record.
Yes, we are seeing.
This is the distal stent. This is the mid stent, means distal LED stent. That.
Okay, it's not working, right? We can change the. It's the picture's a bit gray.
Yes, recording.
It's not moving.
Yeah, okay. We'll have a look again, or we'll change the.
We may have to change the IVers catheters. Back, no?
Okay, our IVers catheter is sort of.
No, maybe that is.
Yeah. So. No, okay, it's not. So let's change the IVers catheter. No, it's problematic.
We can change the catheter.
We will change the catheter. Okay, so we're taking out
Another
this
catheter,
catheter. This catheter, unfortunately, fractured somewhere while we were pushing and prodding and all. And this is a problem. You're working through a 6 French guide catheter. Usually, when we do Aditya crush, we use a 7 French. When we usually go through the femoral route. But here we are using a 6 French, and maybe since I'm not used to a 6 French, we're pushing a bit too hard, and that sort of caused damage to the catheter. So we'll go for another IVers catheter. So now she seems to be settled down.
Thank you, madam. By this time, we can discuss regarding the case. Am I audible to you?
Yeah. Yes.
You are.
Yes. You have done very nicely in a case where patient is hemodynamically unstable, blood pressure fallen, chest pain, critical left main, involving the ostium of the LAD and LCX. This is really a difficult case and really a challenge in the time when there is patient is unstable. And from there, you have made the patient stable, and almost work is also finished. In step by step, you have shown all the steps, and for our younger colleagues, they have learned much more from your case.
Thank
and we
you
are
so much.
Last scene, we like to see the last scene.
Yes. So we will definitely show you the last scene. We'll show you the IVers, and then we'll go for the last scene. Okay. So we've got 5 minutes, so 2 minutes for IVers and 2 minutes for the
Madam, by this time I can draw attention from Dr. Cheem. Dr. Cheem, can you hear me? Hello. Can you hear me?
Yeah, we are hearing you, Dr. Ajam.
Regarding EDC consensus, 14 consensus recommendation, was the carina regarding torque. Second thing, value to be sized by 1 to 1.
The problem is
your sound is not clear, maybe.
Sorry, I can't hear you, sir. I can't hear you, sir. Sorry.
To understand how you calculate fraction is systolic volume. N systolic volume divided by N diastolic volume times 100. Then you get a. Obviously, the heart does not inject all of the blood that is in the heart.
There's some noise here.
50, 60, 70% is value of this injection.
Maybe the catheter got kicked a bit.
Yeah, it's not, and so it's like the IVUS catheter is not going here. Yeah, there's some kinking here. So maybe we'll take the first final angiographic BQ, and then if we have time, we'll try to take the. And I think that's why the first IVUS catheter also got destroyed.
The loop is terrible, actually. Yeah.
Why sure? No, we can get
no, here is the problem.
Actually, there is some kinking.
Yeah,
that
so we'll take a final again.
Yes.
Yeah. So actually, we have done a thorough job of pulse dilatation with a report balloon of 4.5 by 8. So I think the results would have been fine. But it would have been good to have it going. So we can also, she's settled now, we can do OCT, but the time is up because so we'll take the final angio, and if it's a time, we're happy to say
patient ECG,
everything is stable. Yeah.
Stable.
Okay, so let's take the final shot. So things look good, right? And can we have the first picture here? So just to have a recap of what it was actually.
It's just the osteocircumflex that's look a little bit narrow. Maybe another view. Or...
But we went with a 3. You know, we put a 2.75 stent there, but we did the second case with a 3 balloon. So,
pretty good.
Thank you, madam.
Thank you. So we'll take the final shot and we can call it a day.
Any comments, please? Any panelists, those who are in this actually, a lot of panelists. I just recall Professor Prabir Kumar, Dr. Mahbubor Rahman, Dr. Kaisar Nasrullah Khan, Dr. Shams Munwar, Dr. Tamzeed Ahmed, and Dr. Mohsin Ahmed. I know they are with us. And if any comment from our panelists with this scenario.
Yes, it's an excellent work in this emergency setup. Only thing that Dr. Tan was mentioning, there's some still maybe some artifact in the circumflex. Maybe you can do the ultrasound to see later on.
I think it looks acceptable.
Yeah,
it doesn't look bad considering the amount of disease that she had. I think it's acceptable.
I think it's acceptable, yeah. Otherwise, the whole procedure is so nice and good.
You have also dilated with 3 NC balloon, the ostium of the sac.
Yeah.
It got stuck again. The IVUS got stuck here. It gets stuck here. You see, here is the crux of the matter. I'm pulling the okay.
Professor Jamal, have you any other comments? Because already Dr. Tamzeed Ahmed and next Dr. Cheem.
Okay, so we'll say bye to you here. So thank you for giving us the opportunity, and angiographically it looks fine. And we'll take the IVUS if possible and just do it for an academic purpose. Otherwise, everything looks fine.
Yes.
So thank you and goodbye from National Heart Foundation Hospital and Research. And thank you so much.
Thank you, madam. It's really a great job. And it's give a claps for you because it's a nice presentation. Especially, we have learned many things. And our junior fellow, I think they have seen excellent job. And in this actual emergency situation, and I must thank you and your team, and congratulate your team. Professor Mir Jamal, have you any comment? And then Professor Cheem.
Thank you, National Heart Foundation Hospital and Research Institute, Professor Fazilat Malik and her team for doing this excellent job, showing every steps of the procedure clearly, and final result is also excellent. And your team, we know you have told that for success of this type of cases, the secret is the faculty, your associated and your team. And this is really sure that your team must be even much more work they done in this field, and that is why they are also doing very nice with you. And the performer is also very important for his or her number of cases, as because so far I know in Bangladesh left main PCI you have the highest series more than 2200, and this DK crash also highest series of National Heart Foundation Hospital and Research Institute. So I must congratulate you, and I am grateful to you that you have come to this session and you have given us knowledge regarding subject. Now I like to before for that I must have to congratulate all the panelists, Professor Prabir Kumar Das, Dr. Kaisar Nasrullah Khan, Shams Munwar, Tamzeed, Professor Tamzeed Ahmed, Dr. Mohsin Ahmed, and to our colleague Professor Sabina Hashem, and Professor Mustafa Zaman from University Heart Center. Thank you all. And now I'd like to have the concluding remark from Tan Huay. Dr. Tan Huay, Professor Tan Huay.